All right, good afternoon, everybody, because I guess it's after 12, so that means it's afternoon. Very excited to have the Maryland Department of Health with us here today to give us some answers to how the EQIP applications are going to be handled. So just so folks know, because I see we have a lot of new people who maybe haven't attended all the subgroup committee calls, just for kind of level setting and helping out. Uh, I'm Gene Ransom. I work for MedChi. I'm the CEO of MedChi, and I chair the EQIP committee. And then Krista, who I'm about to hand it over to, she works for the HSCRC, and she is the principal staff person for all things EQIP. And Olivia helps me out with the EQIP stuff on the MedChi side. We also have a lot of help from Chris on EQIP, and we have Krista on, and as well, I think Jessica's going to be popping on shortly as well. I don't think she's on yet, but she will be shortly, I promise you. So those are the principal people who kind of deal with EQIP. In year one in EQIP, we had savings. And as a result of that savings, the HSCRC was very excited and they decided to allocate some of it to help us with our primary care shortage problem. And Krista was assigned the incredible task of developing this program, which she did very quickly and work through all the details. So then it was decided that because this is going to be a primary care program, it would be administered by our amazing friends at the Department of Health over in the Maryland primary care sector. And that is why Chad is on here, Chad Perman, and he's got Alice and Emily, and I think he might have some other team members as well. And they are,
Angie,
huh?
Dr. Lindsay.
Oh, Dr. Lindsay, I'm sorry. See, I knew I'd forget somebody on the call as well. And they they are going to be actually answering the questions, and they're going to be the ones who actually administer this grant program. Just for clarification, while the money came from EQIP, it was developed by EQIP, it was developed by the HSCRC. Again, it's going to be administered by our friends at Primary Care. And then secondarily, this program is independent from traditional EQIP, which we have about 50 bundles. And if any of you haven't heard about traditional EQIP, that's a pretty cool program too. You should be involved in it, and you can talk to Olivia or Crystal or myself, and we can get you the details on that. So that is the level setting where we are. And I will stop talking now and turn it over to Krista, who's going to start us off. And she and Chad are going to answer all your questions and make everything crystal clear by the end of this hour. All right, Krista, it's all you.
Yes, thank you so much, Jean, and welcome everyone today. We're really excited to have this sort of kickoff to get all your questions answered to the best of our abilities. And please be patient with us as the policy is evolving, and so we're doing our best to give you answers in real time. We hope to have an FAQ document that will be posted on the CRIS website that we hope to update weekly as policy evolves and we get more answers to questions. So just so you know, the questions that are answered today will be part of that document, and that will be updated ongoing, so folks can refer to that. We have a set of slides. I don't know, Olivia, would you mind driving?
Yeah, just give me one moment.
So basically today we're going to walk through just a few slides just to level set, talk a little bit about timeline, and then we're going to spend the majority of the time answering questions. And thank you to everyone that submitted questions in advance. Please keep the questions coming. And then once we answer those questions that were submitted in advance, we'll open it up to other questions. And it's probably best to submit them through the chat, but also raise your hand. We'll do our best to get to everyone. Whatever questions we don't get to, if you put them in the chat or send them to the mailbox, again, we will update an FAQ document. So all your questions should get answered. So again, just please be patient with us as we work through all of the logistics of that. So terrific. Thanks, Olivia. We have the next slide. So like I said, we're going to do just very, very brief EQIP PC background for folks that have not been on any of these meetings. There are a set of slides and information on the CRIS website, which we link at the end of the document. I just wanted to underscore, though, that really the RFA is the source of truth at the moment because the policy has evolved. So, we've had some questions about looking back at the slides from other subgroups. So I would just, suggest that folks use the RFA as a source of truth, and then the FAQ document that'll be evolving. So this is sort of our brief agenda. You go to the next slide. Next slide. So EQIP PC, again, high level HSCRC in collaboration with Maryland Department of Health, the PMO, MDPCP has worked with partners and stakeholders to design EQIP PC with really the core goal is creating new primary care access in underserved areas of the state of Maryland. And under the proposed program, the state is seeking a small number of organizations for a multi-year commitment under which the organizations would receive startup infrastructure funding in return for providing advanced primary care capacity in those designated focus areas. And we're not going to go over it today, but those designated focus areas are in the RFA. So please take a look at that if you're not familiar with those areas. And as Jean mentioned, to really streamline the state's approach to advanced primary care and given the AHEAD model and all the hard work that the PMO and the MDPCP Program Management Office have done, they'll be really overseeing EQIP PC, and HSCRC will be providing background support and monitoring as well. So it continues to be a collaborative effort, but MDH and the PMO will be in the driver's seat. And just a caveat in small letters at the bottom, we have not received final approval for EQIP PC, and therefore, acceptance into this program for 2025 is pending that approval. We hope to get that approval in the next month or so. We'll keep folks updated, so stay tuned for that. That's about the most detail we can provide on that at this point in time. Next slide. I'm not going to go through all of this, but this is just high level timeline. So we released the RFA on July 18th. We had some delays, so apologies for that. We tried to push out the timeline to give folks time to apply and get their ducks in a row. So thank you for your understanding about that. The deadline for the application is August 30th. And so we are really, that's coming very soon. So if you have questions, please submit them through the mailbox. And I know this is a very compressed timeline, but appreciate your understanding. We'll be reviewing the applications in September. We have a review panel of experts and other folks that'll be looking at the applications and assessing appropriateness according to the rubric. We'll be notifying applicants on October 1st, and then they'll begin program enrollment in October. And the start date will be January 1. That's where the program measurement start date is. And then December 15th, we're hoping to get the payments out to the awardees. But that program measurement start date, we don't expect on that day one that you have everything in place, that you have your panel of patients, and that would be impossible. So that really, think of that as like the program measurement start date. That's when it really, the actual program starts, but not everything needs to be in place at that moment. Next slide. Again, this is just some resources that we have. The EQIP PC website right now is the best place to get information. So keep a lookout for new materials, the deadline August 30th, and then reach out with questions to this email box. So of course, any of the folks, Jean, Chad, myself, others, we're happy to answer any questions as we're able to. Okay, any questions before we go into the Q&A? I mean, that's kind of a weird thing. We'll answer a lot of questions, but any questions on process or logistics or administration of the program? Okay, and I know there were some of those questions in the Q&A, so we also probably be addressing those as well. So if you want to go to the next slide, Olivia, we can start into the Q&A. And Chad and I are going to be walking through these questions. So we'll start, these are in no particular order. We kind of tried to group them in general, MDPCP questions, and another bucket of questions. So we'll kind of start with these general overall questions. And the first question we have here, or what, oh, yeah.
Oh, excuse me. I just want to say a few words before we jump into the questions,
Yeah,
if that's
absolutely.
Okay. Okay. And Olivia, if you don't mind just going back to the previous slides. So, first of all, hi, everybody. I'm Chad Perman. I'm the executive director for the MDPCP Management Office. I know a lot of you, but I'm sure there are others on the line who I don't know, and vice versa. So I just wanted to say hello. A big thanks to Krista and team at HSCRC who have done really the heavy lifting on developing this and are great partners. Same for Jean Ransom and Olivia at MedChi who've been helping facilitate all of these meetings to develop the concept of the subgroup. So big thanks to you as well, and we look forward to continued partnership with you. I did also want to just briefly introduce my MDH colleagues who are also on the line, who also will be helping determine how this gets put in place, the program. So first, Dr. Gingy Lindsay, who is still fairly new, I guess, to the department. She's the Chief Medical Officer. She's also the MDPCP Medical Advisor, and thus is involved in all things primary care that for the department and for the future of the total cost of care model. Dr. Lindsay, if you want to wave and if you'd like to say hello.
You did my full introduction, but hello. All the things that Chad said. Nice to see everyone.
Thank you. And then also, for those of you who are familiar with MDPCP, you're already familiar with my amazing team, including our program director, Alice Sawinski-Rice. Alice.
Hello, everyone. As Chad said, if you're familiar with MDPCP, then you've seen my name, but happy to be here.
As well as our associate director, Emily Gruber. Emily.
Hi, everyone. Good to see you. Thanks for joining today.
Thanks so much. All right, well, let me say just a few other things. So I want to paint a picture here for a second so we understand. I think Krista did a nice job of the overview of what we're hoping to do with this program and driving primary care access. But this program, and part of the reason why my office is getting involved now, is part of a set of primary care programs that we want to have in the state for Maryland, particularly as we move to the AHEAD model, this approach for really a expansive all-payer approach to total cost of care that includes an all-payer approach for primary care and primary care investment. So EQIP PC was developed with the idea that there are certain parts of the state where we don't have enough primary care access, particularly for underserved populations. And if we're really going to use primary care as the foundation for our healthcare transformation, we need to develop access in those areas as well. And so that's been the idea that's driven this. And the idea is that this is a startup program. This is a program for areas where we don't have practices, where organizations like yours hopefully have the capacity to help us develop that. And then prepare and move those practices into advanced primary care programs, both on the Medicare and the Medicaid side. Dr. Lindsay is leading the work on developing a Medicaid program that's going to align with MDPCP, and that's really the destination for these programs. If you don't mind, if you're make sure you're on mute so we don't get too much background noise. Thank you all. So that's where we're going with this. So this is not a program unto itself. This is a program to develop for some new practices who need these supports, but then move them and transition them into our primary care advanced programs for Medicare and Medicaid is where we're looking to go here. So I say all that because what we're going to tell you today and not tell you today in terms of answers is because all of this is developing with the AHEAD model. And as you know, we just got the award for the AHEAD model in July. And we are going through discussions with CMS as to where do all these pieces fit. So there's some places where we're still a little unclear exactly when these pieces are going to start in 26 and 27. And thus there's some ambiguity in terms of exactly how long and how exactly the EQIP PC program is going to work. So I say all that just so that you understand why some of our answers are going to be more vague than we'd like them to be, and certainly more vague than you would want them to be. But in the end, what we're really going to need from everybody is, and hopefully as many of you will apply as possible, your proposals with a sense, an outlining of what do you need in order to set up these practices in terms of resources, in terms of finances, and why is that? And then it's going to be a competitive process. We're going to look at and select the best options for the various parts of the state that we've identified in the RFA. So with all that said, Krista, let's go into the QA now. We got a lot of questions up front.
Yep.
I think that we can address now, and then I'm sure there'll be more questions as we go through this.
Yep. Okay, great. Yeah, thanks for that, Chad. So the first question is, what are the funds and payments intended to cover? I think we're talking about infrastructure payments here. a provider's salary and entire clinic's costs, subsidizing losses typically incurred when taking care of a rural population.
Right. Okay. So good question. Our understanding, this is particularly a question about infrastructure payments, and those payments are intended to support practice startup costs. They can cover any of the above costs listed in this question, including providers, staff, equipment, space, operational costs. But we're looking for you to identify all of that in your application so we understand what you would need in order to do this. And then final approval of infrastructure costs will be determined hopefully during the month of September, which is when we'll be reviewing applications and also having discussions and negotiations with the applicants.
And so just be really clear in your application about all of the assumptions that go into the funding requests. That is key to reduce back and forth and to make sure we fully understand the picture that you're basically trying to paint in your application of the need. Great. Okay, so the next question is around the funding template. It's not clear how to estimate the per beneficiary payments. See the bolded line. How do you recommend we estimate attribution? What are the payment amounts? Do they vary by risk tier? Are they equal to MDPCP?
Okay, good question. So I think we would encourage everyone to submit a proposal for the startup costs, as we were talking about, that include establishing care management and other advanced primary care capabilities, which you might normally think of or would be covered via beneficiary payments. You can use MDPCP and other primary care value-based payment models as guidance, for some structure there, PCMH as well, in terms of payments and attribution. We can share with you, a link to the 2024 MDPCP payment table so you have an idea of what those levels are. But we're going to need to see all of that together in order to understand what are you going to need initially a startup and ongoing in order to continue to provide the care.
Great, thanks, Chad. Next question, what is the timeline for getting a new practice actually set up? It will take considerable time to hire, find space, etc. When is this expected to be complete?
So the timeline, for to set up a new practice obviously varies based on numerous factors, including geography. In your application, you should provide your best assessment of what that timeline is, taking into account whatever the local factors are. Awarded organizations, I guess, should treat infrastructure payments as an infrastructure grant. This is not a planning grant. This is really to get you up and running as fast as possible. And with the idea that it will take some time, but at the same time, we are preparing you to move into both MDPCP and a Medicaid primary care value-based payment program. I guess we can say we anticipate this process may take as little as a year and certainly should not exceed 3 years.
Yeah, and I think just a note there a little bit on reporting, we will be asking, I think we touch on this later, we will be asking applicant awardees to report annually on whether or not their funding has been used to hire the appropriate people or whatever the work plan designated was supposed to happen in that year. We will be very interested to see if those things are in fact happening. And so that will be part of the reporting. But obviously taking into consideration all the factors that it takes to get a new practice starting up, we will absolutely consider. I think we already touched on this. We anticipate hearing back from CMS hopefully within the next month, maybe sooner. And so we will certainly let folks know. We know that that is a critically important part of this. We don't anticipate that the program will not be approved, but we look forward to that stamp of official approval from them. So I'll hop to the next question. How will the shared savings be determined?
So availability of shared savings is going to be determined at a future time. Any shared savings design will be aligned with the advanced primary care programs that we're going to have for Medicaid and MDPCP. Unfortunately, we just don't have any more detail on shared savings at this point.
I think we could safely say that we don't anticipate that it would be wildly different from other shared savings programs that folks are familiar with. But yes, the details and methodology are still TBD. The reporting, what will the reporting requirements consist of?
So still a bit TBD on the exact requirements. I think at a minimum, participants will need to complete an annual progress report. There could be additional reporting requirements determined at a later date. We will certainly keep in mind administrative burden while balancing that with ensuring that the money is being put towards startup and that the organizations are making progress towards the goals.
Great. Excuse me. We can go to the next slide, Olivia. So these are the more general application questions. The first question is, do you recommend including letters of support from community organizations, et cetera, in the application?
So letters of support certainly may be included in your application, but they're not required.
Okay, terrific. Is there a suggested word count? Is it better to include detail or exercise brevity?
There's no suggested word count. I think we all, in our various lives, would appreciate concise descriptions. Certainly you'll want supporting detail. I think that's what we can offer.
And is there a template for the work plan?
No.
Okay. How frequently will practices report to the PMO or to program organizers? We can touch on this a little bit, but
So I think initially we were thinking that it's going to be annual, but as we said earlier, there could be some additional reporting requirements that are developed between now and officially starting the program.
And will annual financial reporting be required on how dollars are being or have been spent?
I think that's likely. So we're tentative on that. It's likely to be at a high level to indicate, which broad categories practices have spent funds on, such as providers, staff, equipment, some of the things that will have gone into your proposal.
Great, thanks. Will practice coaches be a part of this program as they are with MDPCP?
So that's one of the operational things that we're working on figuring out. As you guys know, this was just recently, transitioned over to the PMO as we continue to work collaboratively with Krista and her team. So I think tentatively we can say yes, but no details have been finalized yet.
Do you have any more information on program oversight? They mentioned that administration and structure similar to MDPCP. Will MedChi or the MDH set up a portal that includes attribution and practice performance?
So I think what we can say is there will be program oversight from the state. We still have to work that out with HSCRC and what exactly that looks like, and also with CMS. But there will be some program oversight from the state. And in terms of the portal and attribution practice performance, I think we're planning and anticipate that we'll have attribution and performance data available via CRISP. We will try to make a lot of this as seamless as possible for practices who are going to move on into Medicaid and MDPCP.
Okay, great. So we'll move into the next section, which is where we have a lot of questions. I think we've tried to collapse some of this. We're getting similar questions, but we'll jump right into the MDPCP overlap, which I think folks are very interested in. So can a practice participate in both EQIP PC and MDPCP with different NPIs?
Yeah, so the MDPCP overlap piece is just like everything else. We still need to figure that out, particularly with CMMI, because they operate officially MDPCP in terms of attribution, payments, et cetera. So that's where we really need to get their stamp of approval. But so existing MDPC practices, that are committing to adding new providers in the designated areas, or completely new practices, are eligible to apply for EQIP PC. The application should clearly lay out how dual participation would work for the delivery model. But if you're adding NPIs, we want to understand how does that work, and how the organization will provide what is really the goal of the program, which is net new access to primary care. We don't want to supplant funding that we're already providing through the feds or the state, but we want to provide new access to primary care benefit in the specified zip codes for both Medicare and Medicaid beneficiaries who don't have that access today.
Okay, great. The slides state that MDPCP practices will not qualify for the EQIP per beneficiary payments. Is this true even for EQIP beneficiaries who are not attributed to MDPCP? The attribution methodologies are very different.
So this is probably in part, some of the changes that have taken place in terms of the program design, and probably references some outdated information that was in some of the subgroup meetings. I think the final RFA guidance states that the availability of payments is going to be determined during negotiations, during the application review and negotiations with selected applicants. So what we do know is that duplicate payments for the same beneficiary will not be allowed.
Yeah, so thank you, Chad. I think this next question is in that same vein. I'm just rereading it again. How will MDPCP practices that apply for the program know whether or not they will be eligible for the per beneficiary per month? What are the criteria that will be used to establish which practices will be eligible for the per beneficiary per month? We answered some of that, but I'll let you take that, Chad. Sorry.
No, I think you're right. I think it's largely the same question.
Yeah.
So we'll look to the final RFA guidance. It will have to be determined during negotiations. Obviously, all payment needs in your application need to have associated justifications and should be, built into your proposal. And same thing about the duplicate payments. Yeah.
Great. And if an EQIP PC practice exits MDPCP at some point or never enters to begin with, what would the implications be? Would they need to pay back EQIP funds?
So I don't have a really firm, solid answer to that. What I can say is that the application review panel will be looking for applicants to clearly demonstrate their plan to transition into the Medicaid primary care program and the MDPCP. The state may require, we're still figuring out what this looks like, but I can imagine we may require that awardees will need to sign an agreement stating their intention to transition. Remember, these are startup funds, but these are not startup funds. We want to make sure these practices are going to be successful and sustainable and move into the programs for Medicare and Medicaid.
Great. We received a few late breaking questions before we jump into the live questions, and I'll start with those. Does a timetable exist from the start of the program 1/1/25 to when an awarded applicant has to be providing services? Just a little bit on this, but I'll let you answer that, Chad.
Yes, so I think, Chris, what we could say is, there's no prescribed a timetable. You should specify, that in your application.
In the work plan, yeah. What advice is given regarding developing an operating model estimate if an exact location and costs of operation are still being researched during the time of the application? For example, a site in a specific area is still being researched. Do we rent? Does a viable location exist? Will it require renovation? Do we need to build? This takes time, and we haven't decided on the best site, although we're pursuing.
It's a good question. So I think, you should make your best estimate and note all of the limitations in your application. As we talked about, it's not, this is not going to be you submit and it's a black and white and it's done. We're going to be looking to negotiate and work these things out with applicants that we're interested in. So I think there's time to develop that and to get updates and to figure out what that looks like. And I would say be thoughtful about how you would best use funds, particularly when it comes to brick and mortar. We don't necessarily, is the best use of the money to develop and build a brand new building, or is it to use an existing building or a strip mall that has availability, where you can get, so all of those obviously are business decisions that you guys would make and with detailing your application.
Great, thanks, Chad. The next question we received is, what advice exists if the model of care is being designed as primary care with the potential for specialized services related to primary care, in parentheses, behavioral health?
I'm not sure if I fully understand the question, but I think the question is asked, how do you build in BH if you're not, don't have the full model figured out at this point? I mean, the model of care, as all of you know, for advanced primary care, particularly for MDPCP, is, we want to stand up primary care practices behavioral health needs to be integrated into those services. And given that it's a new practice, that's not going to happen day one, but there certainly needs to be a plan for doing that.
Great, thank you. And lastly, Aladeed's team wanted to know how savings to EQIP PC, if at all, with TCC savings in MSSP. From a previous question, I indicated that MSSP practices would likely have the same restrictions placed on them that MDPCP practices would. Is that still the case given the language in the RFA about current MDPCP practices?
Krista, I think what the question is getting at, we can follow up with Aladeed, but
yeah,
I think the question is getting at what are we doing about shared savings, and can we, and what's available if you are in MDPCP and MSSP. So I think first of all, shared savings still to be determined on if and how that's going to be implemented in the program. And I think, we could say all payments are certainly subject to CMS rules on duplicative payments for beneficiaries.
I would imagine there will be some kind of reconciliation, right, for that. Yeah.
Right.
That's safe to say. Yeah.
Hopefully that answers the question, but certainly follow up with us because I'm not sure we're fully following.
So those are all the questions that we received in advance. I saw a couple of questions coming in through the chat that I can touch on, Chad. So someone asked, so we can take up to 1 year to be up and running.
Yeah, I mean, I think that's what we want to understand in your application. How long does it take to be up and running? I don't think we imagine that that there's going to be no practice operating for an entire year, but maybe that the practice is starting to be put in place. The providers are hired, let's say 6 months in, for example, and that there's clear work that's being done to develop an operating practice and build a panel. So it's not black and white, I would say, on a certain day that we'd be looking for. Krista, would you add to that, or others?
Agreed, 100%.
Dr. Lindsay or anyone else, would you opine on that?
Okay, Bruce said thank you, so I think you answered her question. Okay, would we entertain a project that collaborates with FQHCs?
Yes, I believe the RFA says FQHCs are eligible. And I certainly think, FQHCs is an important component to the safety net in Maryland, and have a huge share of Medicare and Medicaid beneficiaries. So I think we really do encourage collaborations across organizations, including FQHCs.
Next question. Can you receive the per beneficiary payments for attributed beneficiaries in both MDPCP and EQIP PC, or do you give up one for the other? Okay, I think we touched on this. Did you want to say anything more on this, Chad?
Just to make sure, certainly if you have an attributed beneficiary in MDPCP, you cannot also be getting a PMPM for them on the EQIP PC side. It would have to be for different beneficiaries, if we even have a beneficiary payment.
I had one direct message to me. Someone asked, is the scoring going to be similar to what was gone through at one of the prior subcommittee meetings? If you remember, Krista, I think they're referring to, you went through a scoring mechanism for the applications.
Yeah, the rubric.
Yeah.
Yes, and that should be in the RFA, and that is, yeah, we're still following.
It's substantially the same as I think what we went through. Maybe
yes.
The last EQIP subcommittee meeting is the answer to the question.
It has not changed.
Right.
At all, I think maybe some language tweaking, but yep. Someone direct messaged me, how will the program coexist with the AHEAD model? Chad, I'll let you speak to that. In terms of the primary care space, I guess we're talking about. I don't know if.
Sorry, Chris, I didn't quite hear what you said. Can you repeat that?
How will the program coexist with the AHEAD model?
How will EQIP PC coexist with the AHEAD model? So I think you can think of it that the AHEAD model is what our current total cost of care model is, the umbrella structure for all things healthcare transformation, from hospital global budgets to primary care to specialty care. EQIP falls under that as well. So the AHEAD model is going to be the umbrella. Primary care is a significant component of our strategy. EQIP PC is part of the multiple pieces of primary care that we're using. And it's a startup program to build advanced primary care capacity in certain areas of the state that are underserved. And so it's one of our strategies to build up the primary care participation for Medicare and Medicaid in particular.
I don't see any other questions in the chat. Do folks on the line have questions we can answer?
Yeah, hi, Dr. Kaluja.
Hey, Dr. Saluja.
How are you? Quick question. So how is it determined based on, I know there's a set amount of funding that's being offered. I know there are different size practices, different scales of what they think they can do with the money. Is there an approximation of how much approved practices are going to get? So when we send our application and give you the information, we're realistic as to what we're asking for?
Yeah, I think we're going to need to see what your application shows and what you need and your explanation for what you need. I think we don't have a set number, a minimum or a max in terms of what that is.
So there is no cap, there is no minimum.
Correct.
Okay, good to know. Thank you so much.
I mean, I think if folks, this is not changed. I mean, the funding for this program in year one is in total $19 million. So that's public information. And so we will, walk back from that with the number of applications that we want to take and then what the requests are. So
Krista, is that funding for year one or is that funding for the program period?
that's for year one.
Okay.
Hi, this is Raquel Sampson from University of Maryland.
Hi, Raquel. How are you?
I think we lost you, Raquel.
Yeah, she looks kind of frozen.
Okay. Good for a second. Any other questions?
So what should people do if they have questions after this and what is the plan and how you're going to respond to them? Chad?
Yeah, good question. So, and Krista, correct me if I have this wrong. If you have more questions, please send them into the inbox that we had earlier. If we can go back to that slide, EQIP Primary Care, I believe it is. If you can send in your questions there, we will go through that on a regular basis. Don't know exactly the cadence, probably weekly, and respond to you. What we will also do is include those responses in a document that's going to be on the EQIP Primary Care website at CRISP. And we'll just continually update that as we have more information so everyone can see the responses to those. Obviously, the sooner you have questions, particularly as it relates to your application, the better we get them so we have time to generate a response and respond to you.
Another question in the chat. Just want to clarify, would it be safe to estimate an EQIP primary care PBPM based off of our MDPCP, PBPM, Benny rates to factor zip and risk tier for patients?
I won't comment on whether it's safe, but I would say that's not a bad idea on how to at least develop your estimates on how much it's going to be and just explain that's how you're determining how much it would be. Remember, this program is not meant to compete with MDPCP. It's meant to prepare practices to move into MDPCP.
Thank you, Ted. Did our friend, is she still frozen? That was trying to talk earlier.
It's Raquel. I'm not
Okay.
frozen. I was just putting it in the chat in case I freeze again. But my question is, you're anticipating additional funding beyond the 19 million for years 2 through 5. Is that what I'm to understand?
I think we need to Chris, I'm going to suggest we don't answer that because I think we need to just double check on that.
That substantially impacts the way the proposal will be framed. So I just want to make sure that
Raquel, I think you should still build your proposal, assuming however number of years you're thinking about you're needing to start up a practice, and what it would take to do that. And whether it's 500,000 or 2 million, whatever the number you think it's going to be, 19 million is the number we're using as sort of a bucket right now. Let us just clarify, and we will clarify in writing about the number of years that those dollars are available.
All right, any other questions from anybody? I just want to make one last pitch for traditional EQIP, which is an advanced payment model. The open enrollment is going on until Friday, August 30th as well. So for those of you who have existing practices, it's a really good opportunity. If you need help, you can reach out again to Olivia, myself, or Jessica, or Crystal. And I don't know if Chad, you or Krista have any closing comments.
Krista, anything from you?
We just got another question in the chat. The person said, I apologize, I came in late. That's okay. Our office is already in the MDPCP program. Should we move forward with this program as well?
So first of all, thanks for jumping on. And we want to keep everybody in MDPCP. We don't want people leaving for EQIP PC. But if you are in the specified zip codes and believe that you can add access for additional beneficiaries for Medicare and Medicaid in the area, and would be able to bring on, let's say, additional providers to expand that access, that's the kind of application we'd be interested. Or if you wanted to develop a separate site or some other way you would do it, we'd be interested in that. But we're not looking for you to shift from MDPCP into EQIP PC. Hope that answers the question.
And Michael, I recorded this. We're going to post it up, and I'm going to get it up very, very quickly, and we're going to send it out to everybody. So Chad actually answered that question in a little more detail earlier too. So it'd be very helpful to watch the beginning of the presentation. And I say that for anybody else who dropped on late. We'll get it up quickly and get it out and make sure that everybody has access to the same information. All right. Any closing comments, Chad or Krista? Are we last call for any last minute questions?
Nothing for me. Thanks, Jane. Thanks, Chad.
Just a big thanks to MedCI and HCRC for your partnership. And thank you all for making time today at short notice so we can talk through this. And we'll continue to answer your questions and look forward to some really great proposals.
And crisp too. Don't forget crisp.
And crisp.
Yeah. No, this is really cool. All this stuff we're doing. I mean, to have the private sector and, our HIE and the state all working together, we're getting a lot done. It's kind of cool.
Yeah.
You know?